I, Dr. Sushila, Medical Superintendent, Apollo Cancer Center, Chennai, am your host for today's event. Chronic nerve pain or neuropathic pain is a debilitating condition caused by nerve damage from diabetes, injuries, infections, or cancer treatments, which manifest as burning, tingling, or stabbing sensations and significantly impact quality of life. While conventional treatment often provides limited relief, a breakthrough at our center, Apollo Cancer Center in Penampet, has redefined pain management. Our team of specialists performed India's first dorsal root ganglion stimulation surgery using a spinal cord stimulator, offering life-changing relief to a 30-year-old patient from Oman. This innovative procedure highlights our commitment to advanced healthcare solutions for chronic pain. With that preamble, we begin this event with a welcome address by Mr. Harshad Reddy, Director Operations, Group Oncology and International. Dr. Appaji Krishnan, Senior Consultant, Spine Surgery, and Dr. Anand Murugesan, Senior Consultant Anesthesiologist, to join us on stage, and please be seated. Inviting Mr. Harshad to please deliver the keynote address.
We are honoring a breakthrough that redefines pain management and reinforces our mission of transforming healthcare. The medical milestone we celebrate here today is the successful completion of India's first spinal dorsal root ganglion stimulation procedure. This adds yet another dimension to this commitment. The expert spine surgery team at Apollo is adept at performing challenging and complex spinal deformity surgeries in children as well as adults. Through cutting-edge technology, meticulous planning, and a multidisciplinary approach, we have demonstrated the possibilities of transforming lives even in the most complex cases. This accomplishment owes its success to the expertise and passion of two brilliant clinicians and the stellar teams across ACC. Dr. Appaji Krishnan, Senior Consultant in Spine Surgery, whose skill and innovation made this life-altering procedure a reality, and Dr. Anand Murugesan, Senior Consultant Anesthesiologist and Interventional Pain Specialist, whose insights into non-operative chronic pain management are redefining cancer care. Let's give a big hand for our doctors. Together, they represent the heart of Apollo Cancer Center's promise, which is to deliver excellence at every touch point and create possibilities where none seem to exist. Today, Apollo Cancer Center is not just a healthcare institution. It is a global destination of hope as people from 147 countries come to Apollo in search of answers, often for treatments unavailable elsewhere. With advancements like the first pencil beam proton therapy center in South Asia and the Middle East, Apollo Cancer Center continues to strengthen the global battle against cancer. The story of the young man from Oman whose chronic pain was alleviated through this revolutionary procedure underscores the very essence of why we do what we do. Chronic pain robs individuals of their dignity and joy, and through this achievement, we have redefined possibilities for countless others worldwide. To our friends in the media, I extend my heartfelt gratitude for your role in amplifying the story of hope and innovation. Chronic pain is a silent epidemic affecting millions, and through your efforts, we aim to inspire patients and practitioners alike to explore transformative approaches to care. However, even as we mark this milestone, we are reminded that Apollo's journey is far from over. With every achievement, we reaffirm our responsibility to continue to push boundaries, delivering care of the highest standards and ensuring that every life we touch experiences healing and wholeness. Thank you for joining us today.
We next bring to you a presentation by Dr. Appaji Krishnan, Senior Consultant Spine Surgery at ACC. Dr. Appaji shall address us on clinical milestones and robotic and complex spine surgery.
What we did for this patient, as Mr. Arshad said, pushed the boundaries. So a patient approached us because he is exhausted all points of possibilities of pain alleviation. And we had just read about it, and it's not been introduced or done in India before this patient had approached us. And then we actually went ahead and helped him out. So I'll just go through. This is a team, so we are a big team of people. So the total experience of the team is more than 60 years. And this is our routine work. It's not, the pain procedure was one of unconventional way. So these are the routine works we do, routine day in the hospital. So patients like this get treated by us as a spine surgery team. So when patient like this gets surgery done, and then they go back happy. So again, a patient with scoliosis, and these are deformity surgeries, and we have this novel thing, like what we do is do a non-fusion scoliosis surgery. This is done only in our unit in the entire country, and almost in Southeast Asia, we can say. Out of Australia and Turkey, in Asia, no other center does other than our center. So about this patient, so this was a 30-year-old gentleman. So he had a testicular tumor surgery done 2 years before. And then post-surgery, there was because it's a tumor, so operation is done at a level higher, and there was this nerve which supplies the testis, which is cut. It is cut routinely for this surgery, but what happened, that nerve edge grew into a small tumor called neuroma, and then it started causing him pain. So he started feeling the phantom pain, that he had pain, severe pain, debilitating pain, that he could not even live his normal life. So he used to be like awake all the time, sleep only an hour or two. He got addicted to lots of opioids, and then he was treated by many pain physicians, and then they had given a precise block for that nerve, and then he had a very small percentage of relief with that. And then they did this nerve stimulation once, which helped him. So he had a brief period of pain-free life, but he did not know how to get it permanently. So he had come to us. So once he came to us, then we had to have a team of specialists. So we have to know that whether he's faking pain, whether the pain he's feeling is true. So we have to have a psychiatrist's opinion. Then we had the pain specialist see him, so that he is sure that this is the cause. So if we treat him, because this is not a primary or a first time procedure, so we wanted to be 100% sure. And then I was also involved because it was in the spine. So then we all decided, yes, this patient requires such a procedure. So we have this spinal cord stimulator, and we went and found out suddenly, then we wanted to do this procedure, and we did not have the wherewithal. That's the machine which is used for dorsal root ganglion is not available in the country. And then we found out that there is a spinal cord stimulator. So we made a small innovation. We put this spinal cord stimulator electrode into the nerve root to stimulate the dorsal root ganglion. I think Dr. Anand will explain in detail how it works. So as I said, this is the nerve which got damaged. So it supplies his inner thigh, the groin area, and other places. So he had severe pain. He used to lie down in a crouched position all the time. He cannot even extend his leg and sleep properly. So we had to go and do this procedure. So we use this stimulation. So we put that lead inside, as you can see. There's a lead inside the spinal canal. You can see a small lead coming in, and then that wire is connected to a stimulator. So this machine gives a small dose of electricity to that nerve. So the pain which is generated at the lower level is actually gated, that is stopped or filtered at that root level, so that his brain does not perceive pain but perceives this small electrical stimulation, which over time he will not even mind that electrical stimulation. So that's how this procedure we did. So we did initially a trial because we had to be sure. So we put a trial electrode, gave him a external stimulator, which he kept stimulating for 3 to 4 days. Once he was satisfied, and we also found out that he was completely normal, he could sleep 6 hours, 8 hours after that. Then we went ahead and put this device inside. So that's what we all say. So we used an unconventional way to do the thing and to do more to the patient. So it was actually a patient who had so much of pain. So we had to innovate, get things done, and even though it was not available, we had to get another device which can be used in this way. That was the innovation. Thank you all.
The next presentation is on non-operative chronic pain management in spine ailments by Dr. Anand Murugesan, Senior Consultant, Anesthesiologist and Interventional Pain Specialist at ACC.
Thanks, Mr. Harshit, for leading us on the journey of cancer care. And I have to thank Ms. Sheila ma'am and Sugandhi for organizing such a wonderful meeting here. So there are many non-surgical interventions available in back pain, in spine ailments. So it's actually a multidisciplinary work, like the pain specialist will work along with the spine surgeons and the physical rehabilitation specialist. So it's a multidisciplinary approach, like where we can deal with chronic spinal ailments as a 360-degree approach to treat and to give the best to the patients. So the pain is not just the physical pain. Pain has got a strong, the emotional and the psychological impact on the patients. Like previously it was just dealt with in only the physical pain line. So, but now like so much emphasis on pain management, because after some time, once the pain becomes chronic, you get the emotional and the psychological component added to it, and that particular time it becomes extremely challenging to treat the pain. So as this slide clearly says, like the chronic pain is any pain which is lasting more than 3 months. Once the pain becomes chronic, the chronic means like the pain lasting more than 3 months, we term it as chronic. So what is the significance of it? You can see like there may be a sort of anxiety involved, and the depression, the suicidal thoughts. So once the emotional and the psychological components adds to the chronic pain, then it becomes extremely difficult. That is what has happened on this particular patient who has been suffering with this groin pain after his seminoma testis pain, and like where the many experts tried treating him, and by then the pain got really magnified and he has to come here to get his treatment. So the chronic pain is extremely challenging to deal with, where we have to really do a multidisciplinary approach where the role of all the experts coming together and help the patient using the technology. So as I mentioned, there are many treatment options available for the spine ailments. So of which the interventional techniques are gaining popularity because for simple reason, it is very target oriented. Previously, like it was like more of a pharmacological. So as we know, like during pharmacological therapies, we'll be having a lot of side effects due to the medications, especially the opioid usage. And one side, the side effects of the opioids, the another side is it's an abuse. So to counteract with that, like the interventional techniques as emerging by leaps and bounds, because it is like more targeted. You deal with the pain generator where exactly the pain comes, and the patient gets very superior pain relief, and we are eliminating the pharmacological side effects on them. So few of them are like an epidural steroid injections we offer for a patient with a discogenic pain. They are all like fluoroscopic guidance and more precisely done. And this is for a facet joint. Like this is a disease like usually like every individual will get after their 5th decade due to their wear and tear process because of their lifestyle issues. Like they'll be getting this facet joint arthritis, predominantly presents with back pain and pain, especially due to the changing postures. So we can do a very good targeted interventional pain management techniques on these patients that gives excellent relief to them. So, and I still remember our chairman always used to tell, like, even if it helps one patient, like we should get the techniques and technologies to our institution, to our India, like so that like to give the best to our patients. So one such innovation is the cool radio frequency ablation, like where you really ablate those nerves which are responsible for taking the pain signals to the spinal cord and brain. So thereby you are giving the targeted therapy and then alleviates the pain. So this is for your low back and this is for your neck pain. So this cold radio frequency is one such innovations, helps the patient with your neck and low back pain. So similarly, your sacroiliac pathology, which is like again a distressing problem for the pregnant, post-pregnant women, like because of their pelvic muscles which are weak, like post-pregnancy or maybe sometimes during pregnancy, they suffer with severe pain. Then we can offer them the good targeted pain relief to them. Why I'm insisting on pregnancy, because like we can't offer them medicines, because the medications will cross the placenta, it may have an adverse effect on the fetus. So like these are very targeted and safe even on pregnancy, so where it alleviates the pain, back pain due to pregnancy, and even on non-pregnant, even other patients as well. So this is another technique, radio frequency ablation. Like apart from cool radio frequency, we have got this technique available in Apollo, like where we can deal with all the neuralgic pain. So the concept is very simple. Every pain is mediated through a nerve. So we know which nerve is the cause for the particular pain. Reach those nerves to the images or to the advanced imaging modality we have, and then do an ablation through this radio frequency ablator. Thereby you are putting a gate and blocking the pain signals and alleviates the pain. Of course, this is more relevant for cancer survivors with a spine metastasis, like the tumor spread to the vertebral body and it causes collapse of the vertebrae, causing vertebral body compression and pain, where we can offer them this incredible good technique, like to strengthen the vertebral body and alleviating the pain. So this is a one technique we offer to patients like who has already been done the spine surgery, and sometimes they fail. So we do get some failed spine surgeries as well. So 20 to 30% of spine surgery generally fail, sometimes due to many reasons. So like where reoperating them will cause more scarring and more pain. So where we go reach the operative site through the images, do the scar lysis with our radiosol lysis technique, and thereby relieve their back pain. So this is a good treatment option available for the failed back spine. So this is what like we have done on this patient. It's called neuromodulation. I would like to emphasize a little bit more on this because it's the future. Like we are moving from ablation to stimulation. Previously, the previous slides I was mentioning about the nerve block, which means like you are blocking it, you are burning it, you are ablating. It's a neurodestructive procedure. So now this is a recent advance happening in pain management, like where you are stimulating the nerve. So once you stimulate the nerve, it hyperpolarizes the nerve, and then you are filtering the pain signals. So the pain signals get filtered at the spinal cord level, thereby it will not be taken to the brain, and thereby you are alleviating the pain. So this is a way forward for many chronic pain conditions, for cancer and also for the non-cancer pains like diabetic peripheral neuropathies, post-herpetic neuralgias, and many neuralgias like trigeminal, so many. So this neuromodulation is like the way forward. It's coming up in a very big way to deal with the chronic pain. So one is the spinal cord stimulator, which is already in practice for many decades, where you place the electrodes in the dorsal column, stimulate the dorsal column, and thereby you are blocking the pain signals reaching the brain. And in this particular domain, we have got the dorsal root ganglion, which is the most recent advance and more precise, where you place the electrode close to the dorsal root ganglion, where that is your relay center for all your sensory inputs. Wherever you have pain, the pain takes to the dorsal root ganglion of the spinal cord. That's the powerhouse of the sensory inputs, like the pain signals goes and relays there. So place the electrode there. You can see in this picture there is an 8 contact lead which is placed parallel to the dorsal root ganglion, and you stimulate it. You stimulate it, it hyperpolarizes the neurons, and you're putting the gate there. So the pain signals get filtered there. It will not be taken beyond the spinal cord to the brain, and thereby you get the good pain relief. So this is the latest technique and effective technique to deal with chronic cancer pain and chronic non-cancer pain as well, which we have done on this particular gentleman, and post treatment 3 months is doing incredibly well. So this is what we did as a team, myself and Dr. Appaji team. We have done this, and it's given an extremely promising result on this patient, and is doing really well. Good to see them doing really well. So what we would like to say, it's a new paradigm, like it's revisited. Those days are gone, like where you have people say like it's pain, okay, we should live with the pain. No, now the pain has revisited. So like we have to take it very, very seriously, and it is a human right for every patient to seek a good pain relief, and it has been approved as the sixth vital sign, like your heart rate, blood pressure, NAB, blood pressure, ECG. So it's a sixth vital sign. So, and more than anything, it's from patient perspective, they just want a pain relief. You can treat the patient, you can treat the cancer. We have a cancer specialist, medical oncologist, radiation oncologist, surgeon. Of course, they all do their work, but what the patient needs from patient perspective, they just want to get rid of the cancer pain. So it's a real new ray of hope for all the cancer survivors, and we should give the best to them. Thank you so much for the opportunity. Spinal cord, the dorsal root ganglion, what we are talking is this one. So this particular nerve directly starts from the spinal cord. As you see here, there is one small, contoured, round, contoured one. That is your dorsal root ganglion. That's the powerhouse. All the pain that starts from the affected area will come to this place only finally. From this place, it enters the spinal cord and goes to the brain. So we are placing this particular electrode, which is an 8-contact electrode, which is precisely, we enter the spinal cord of the same level like this, and then it comes out from the other side of the spinal cord, and this particular 8-contact lead is placed along the dorsal root ganglion. So once this is placed, we have a battery here, and that will be connected to this lead. This is a lead. This is an electrode, this is a lead. This lead will be connected to the battery, and there are some settings we can stimulate it. Once you stimulate it from this battery, that stimulation happens here. So this particular dorsal root ganglion, this nerve gets stimulated. So the pain signals get filtered here. So after we place this for 3 days, patient will stimulate, and then he will feel how much he gets the relief. Once he gets the considerably good relief for 3 days, we have to connect this particular lead to this battery. It's called implantable programming device. This will go inside the body under the skin, so that nothing will be visible from outside, and then we can control this programmer from outside with a remote control based on the patient needs. So in case if the patient pain goes up, we can adjust the programming parameters from outside, and we can decrease the pain. So nothing will be visible outside. So that's how it works out, and Dr. Apaji Krishnan will explain to you in Tamil.
ஸோ ஸ்பைன்ன்றது வந்து ரெண்டு போர்ஷன். எலும்பு, தட்ஸ் த வெர்டிபிரல் பாடி. எலும்பு தனியாக, அதுக்கப்புறம் நரம்பு மண்டலம் தான் ஸ்பைனல் கார்டு. ஸ்பைனல் கார்டு வந்து எலும்பு மண்டலத்துக்கு உள்ளார ஒரு கெனால் வழியாக வரும். ஒரு டிவிஷன்லேயும் ஒரு வெர்டிபிரா, அதாவது போனுக்கு நடுவில் இருக்கிற ஒரு டிவிஷனில் தான் நரம்பு வரும். ஸோ கழுத்துலேருந்து வர்றது வந்து நம்ம கைக்கான நரம்பு. செஸ்ட் போர்ஷன் வந்து நம்ம செஸ்ட் அண்ட் அப்டமனுக்கு வர நரம்பு. கீழே வர்றது லம்பார் ஸ்பைன், L1 L2 எல்லாம் நீங்கள் கேள்விப்பட்டிருப்பீங்க. ஸோ லம்பார் ஸ்பைன் வர்றது வந்து நம்ம காலுக்கான நரம்பு. ஸோ அவருக்கு இந்த நரம்பு பார்த்தீங்கன்னா ஸ்பைனல் கார்டில் நரம்போட வேலை 2 வேலை இருக்குது. ஒன்று வந்து நம்ம மூளையிலேருந்து கையை காலை அசைக்கிறதுக்கான எலக்ட்ரிக்கல் ஸ்டிமுலேஷன் எடுத்துகிட்டு போகும். இன்னொன்று வந்து நம்மளோட உணர்ச்சிகள், தொடுறது, சூடு, குளிர்ச்சி, இல்லை நம்மளோட பெயின் எல்லாத்தையும் வந்து பெரிஃப்ரியிலேருந்து பிரெயினுக்கு திரும்ப எடுத்துகிட்டு போகிறது. ஸோ அந்த பெரிஃப்ரியிலேருந்து வர ஸ்டிமுலேஷன் வந்து இந்த டார்சல் ரூட் கேங்லியான்னு சொன்னார் இல்லைங்களா, அந்த நரம்போட ஒரு வீக்கம் இருக்கும். ஸோ அந்த இடத்துல தான் ரிலே ஆகும். ஸோ அந்த ரிலேவை வந்து இந்த ப்ரொசீஜர் மூலம் நம்ம எப்படின்னா, இது ஒரு எலக்ட்ரிக்கல் ஸ்டிமுலேஷன் தான். ஸோ ஈவன் திஸ் நர்வ் ஸ்டிமுலேஷன் வந்து ஒரு எலக்ட்ரிக்கல் மில்லி வோல்ட்டில் இருக்கும், 90 மில்லி வோல்ட்டில் தான் இருக்கும். ஸோ நம்ம இந்த எலக்ட்ரிக்கல் லீடை வந்து, ஸோ இப்போ ஒரு கேட் மாதிரி இது உள்ளார நம்ம இன்சர்ட் பண்ணிடுறோம். ஸோ நம்ம பர்குட்டேனியஸாக இன்சர்ட் பண்ணோன்னா அந்த நர்வ் மேலே வந்து அது உட்காந்துக்கும். ஸோ இப்போ இந்த நர்வ் கண்டினியூ ஆகுது. நம்ம எங்கே இப்போ காலில் ஒரு வலி இருக்குது, அங்கேருந்து வர வலி வந்து இந்த நர்வ் இங்கே தான் வந்து ரிலே ஆகணும். பட் இந்த இடத்துல நம்ம புதுசாக ஒரு ஸ்டிமுலேஷன் கொடுக்குறோம். அந்த நர்வ் இம்பல்ஸ் ஒரு 12 மில்லி வோல்ட்ஸ், 8 மில்லி வோல்ட்ஸ், அப் டு 20 மில்லி வோல்ட்ஸ் வி கேன் கிவ் அன் இம்பல்ஸ். ஸோ அந்த இம்பல்ஸ் ஜெனரேட் பண்ணும்போது கீழேந்து வர உணர்ச்சி இங்கே நின்றுடும். இந்த உணர்ச்சி தான் நம்ம பிரெயினுக்கு போகும். ஸோ வி டோன்ட் ஃபீல் த பெயின் அட் ஆல். பெயின்ன்றது ஒரு உணர்ச்சி தான் இல்லைங்களா. பெயின் இருந்துட்டு இருக்கும் ஸ்டிமுலேஷன், பட் அந்த உணர்ச்சி நமக்கு தெரியலன்னா ரியாக்ஷன் இருக்காது. ஸோ அது கண்ட்ரோல் பண்ணுறதுக்கானது தான். ஸோ இது நம்ம ரெகுலராக இந்த வயரை வச்சுட்டு, இதோட ஸ்டிமுலேட்டர் வந்து இந்த ஒரு பேட்டரி இருக்குது. இது என்ன பண்ணோன்னா, இதுலேருந்து அந்த பல்ஸ் ஜெனரேட் ஆகும். ஸோ அந்த பல்ஸ் ஜெனரேஷன் வந்து எவ்ரி மினிட்டுக்கு வந்து நம்ம எத்தனை தடவை அது ஸ்டிமுலேட் பண்ணோம் அந்த ஹர்ட்ஸ் சொல்கிறோம் இல்லைங்களா. ஸோ 12 ஹர்ட்ஸ் இல்லை 16 ஹர்ட்ஸ் இல்லை 30 ஹர்ட்ஸ். ஸோ ஒரு 4 செகண்ட்ஸுக்கு ஒரு தடவை இல்லை 5 செகண்ட்ஸ்க்கு ஒரு தடவை 10 to 12 மில்லி வோல்ட்ஸ் அது நம்ம அட்ஜஸ்ட் பண்ணணும். அதான் ட்ரையலிங். ஸோ அந்த ட்ரையல் பண்ணும்போது இந்த டிவைஸ் வச்சுட்டு அவருக்கு எவ்வளோ கரண்ட் தேவைப்படுது அந்த இதை கண்ட்ரோல் பண்ணுறதுக்கு. இதில் இன்னொரு டிஸ்அட்வான்டேஜ் வந்து சில பேருக்கு அந்த கரண்ட்டோட உணர்ச்சியும் தெரிய ஆரம்பிச்சிடும். ஸோ அதையும் நம்ம ஃபில்டர் பண்ணி ரெண்டுத்தையும் கண்ட்ரோல் பண்ண அப்புறம், ஏன்னா இது வந்து ட்ரையல் வந்து சீப்பர். இந்த டிவைஸ் உள்ளார போட்டும்போது நம்ம இட் இஸ் எக்ஸ்பென்சிவ். ஸோ இது நம்ம கண்ட்ரோல் ஆயிடுச்சு எல்லாருமே சாட்டிஸ்ஃபைடு ஆன அப்புறம் தான் இதை உள்ளார போடும். இது எல்லாமே உடம்புக்குள்ளார இது கட்டே இருக்காது உடம்புல எங்கேயுமே. இது ஆப்ரேட்டிவ் கிடையாது. ஒரு ஊசி வச்சுட்டு இதை இன்சர்ட் பண்ணுறதுக்கு மட்டும் ஒரு சின்னதாக இவ்வளோண்டு சைஸ். ஸோ இங்கேருந்து ஒரு 1 inch 1.5 inch ஒரு கட்டு பின்னாடி வச்சுருவோம். ஸோ இது எப்படின்னா இது அவர் பேஷண்ட் கையில் ஒரு ரிமோட் இருக்கும், நம்ம டிவி ரிமோட் மாதிரி. ஸோ அதை வச்சுட்டு அவர் வந்து அந்த ஃப்ரீக்வன்சியும் அந்த கரண்ட்டோட தன்மையும் இன்க்ரீஸ் பண்ணிக்கலாம், டிக்ரீஸ் பண்ணிக்கலாம். ஸோ சில பேருக்கு அந்த பெயின் போயிடும், அந்த கரண்ட்டோட இம்பல்ஸ் இருந்துகிட்டே இருக்கும். ஸோ அவர் கரண்ட்டை கம்மி பண்ணணும்னா பண்ணிக்கலாம். சில பேருக்கு பெயின் அதிகமாகிடுச்சுன்னா அந்த கரண்ட் இம்பல்ஸை இன்க்ரீஸ் பண்ணிக்கலாம். ஸோ இதுதான் இது மெயினாக வந்து யூஸ் பண்ணியிருக்காங்க. பட் ஸ்பைனல் கார்ட் ஸ்டிமுலேட்டராக யூஸ் பண்ணியிருக்காங்க. டிஆர்ஜி ஸ்டிமுலேட்டராக இதான் ஃபர்ஸ்ட் டைம் இந்தியாவில் யூஸ் பண்ணது. அதுதான் எங்களோட மெயின்.